So our next speaker is Dato Dr. Mohamed Hassan Haji Muhammad Ariff. He is a consultant anesthesiologist at Institut Jantung Negara and the Vice President Medical of the Medical Legal Society of Malaysia. Dato Dr. Hassan holds an MBBS from Monash University and a fellowship in anesthesia from Royal College of Surgeons in Ireland and an LLB and LLM in healthcare and medical law from the University of London. Very hard for me to say this, Dato. Okay, so he's also has been certified as a mediator by the Bar Council of Malaysia. Without further ado, I would like to invite Dato Dr. Hassan to deliver his lecture. The platform is yours, Dato.
Thank you, Prof. Selamat pagi, good morning, Assalamualaikum all. As Prof has introduced me to you, I am basically an anesthetist, a doctor, but my interests have always been in medical law. I stumbled into it accidentally because I was asked to write a few expert reports initially. And once I started writing medical reports, I mean, after a while you get to go to court to give your evidence in court. And I realized that once I go to court, the doctors who come up in the stand are really clueless as to the procedures and how to defend themselves, or how to address the judges and the lawyers and things like that in court. So our court protocol is absolutely abysmal. We are not taught medical law when we are doctors because we do not see. But I think it's going to become a big issue coming up in the next few years or the next 5-10 years. We have more medical graduates, we have less teaching facilities around because we have too many medical graduates to train and things like that. So I think we have to be very careful about this. And since you all are third year, fourth years coming out, going to become specialists, these new doctors with less experience than when you became housemen or NOs, they will pose issues to you when you become specialist consultants and heads of department. So you have to know a bit of medical law before you actually practice as specialists or consultants. So I will start my lecture. I will stop my video. Okay. All right, as Prof has introduced me, I have a few qualifications, a few interests at the moment. And I actually teach medical law at one of the universities, which has a master's in medical ethics and medical law, and I teach on the negligence part, on the medical negligence and clinical negligence. Okay, if you look at healthcare, is healthcare hazardous? Healthcare actually is very, very hazardous. We think that we have come out and made healthcare safe compared to what we were 50 years or 60 years ago. But if you look at the incidence of fatalities, encounters with everything that is happening around us in our life, healthcare actually is not safe. It is less than 1 in 1,000 cases that have issues, as close as to mountain climbing or bungee jumping. In fact, the safest are airline schedules, airlines and nuclear power station, nuclear power regulations and things like that. They're very safe. But healthcare per se is not very safe, despite what we think that we have done in the last 50, 60 years. And as doctors, we would like to be remembered as somebody who has helped patients. We do not want patients to remember us as a cause of fatality or death in one's family, as this picture shows. Some people can be very, very vindictive and they won't forget you. Vengeance is all on your mind. Now, the talk today is very simple. I'm going to talk about negligence, definition of medical negligence, types of negligence and definition of medical negligence, the components of medical negligence. I'll give you some examples of medical negligence cases, and which parts of medical negligence are important to you as doctors. And I'll give some data on medical negligence in this country, basically data on Ministry of Health data, because we do not have private practice data that I can talk about. Okay, now what happens when the patient is dissatisfied? Of course, most people say the patient can bring the case to court, and this is where civil proceedings or legal proceedings happens. And most legal proceedings in medical negligence happens in a civil court. Very rarely, medical negligence can be classified as gross medical negligence that comes under the purview of a criminal investigation. This is when you cause death and things like that, and you're grossly negligent in your practice that it becomes so bad that even your closest friend will not uphold you and say that you are doing the right thing. And the third thing that can happen is that we don't go to court, we go to arbitration or mediation. And in terms of medical negligence, I think medical mediation is the way to go. And I think Ms. Shanti will talk about it later at the end of this, in the fourth talk. The second thing that can happen to you if a patient is dissatisfied, they can complain to medical counsel, which Datin Anit has already enlightened you in the previous lecture. And this is an MMC hearing. And in an MMC hearing, you have to remember that if you are in private practice, most of the legal indemnifiers would send you some help in the medical counsel hearing. But if you are in the Ministry of Health, I do not think the Ministry of Health will provide you any help when an MMC calls you up for hearing. I'm stand corrected on that. Because in an MMC hearing in the Ministry of Health, if you're a doctor in the Ministry of Health, you go there alone. You have to find your own legal representative or some advisor to assist you in your MMC hearing. Whereas if you're in private practice, the medical indemnifier that you are insured with will assist you. I have been on both sides. I've been to the MMC as a so-called defendant, and I've seen this from an ethical unit in the MMC as well. So I've seen on both sides. So as a person, I've seen the medical side, I've seen the legal side, I've seen the defenders as a plaintiff and as a defendant as well. So I've seen both sides in one, except I haven't practiced law. And thirdly, they can complain direct to the hospital. So this is an administrative issue. Each hospital that you go to, please make sure that every hospital that you go to has at least a grievance mechanism to handle patient complaints. And that should have, every hospital should have a grievance, hospital grievance committee. And I see that a lot of hospitals in Malaysia do not have a hospital grievance committee. So when the patient comes to complain to the medical director takes it upon himself or appoints somebody, a few people ad hoc to handle this when it becomes escalated. So we do not have people in the hospital who are trained. We need every hospital, major hospitals in this country, especially public hospitals, to have a grievance, a patient grievance committee or council. Doctors who are trained how to handle complaints, doctors who are trained how to approach patients, talk to them, even though they are not involved in the case. There must be a group of doctors who are quite well prepared. Only then the patients will feel happy. Patients complain. What normally happens is that hospitals say we will not entertain you until we have done our internal investigation. Internal investigations take 3 months, sometimes 6 months before they actually even address the patient. So the patient do not want to wait 3 to 6 months before he gets an answer from the hospital. They need to talk to somebody. And this is what I find that most hospitals do not have. Now, doctors, what are your liability towards your patient? You can have a contract with your patient. This is very rare in the medical field because contracts are very specific in what they want. You can have a tort of trespass. This is basically a crime, which is issues in consent. And we have a tort of negligence. So in torts is a tort by medical terms is a wrong from one person to another person, in contrast to a crime when the state and the person. When the state and the person is the public prosecutor that prosecutes you. In a tort is another individual, another private person can sue you. So what we are talking about here is the thought of negligence. Consent is a big issue, which is another big topic, which I can talk to you about for a few hours, which I talked about my students in the university. Today, we're going to talk about the thought of negligence. What do we mean by negligence? Negligence can be civil, which most doctors are involved in, or it can be criminal. Okay. In civil negligence, there is no law that you broke. It's your actions and your guidelines that are laid down by your head of departments, or hospital SOP, or nowadays most of us follow guidelines by our societies and by our College of Physicians, College of Anesthetists, College of Surgeons. They have guidelines on how to handle things, how to do things correctly. Okay, so this is a breach of that. Whereas in a criminal negligence, there is a clear violation of the law. So there's a difference there. One, there is a statute, there's a law that says so. One, there is no law, but it's just our guidelines or our practice, which is not up to standard. And this is in civil negligence is absence or lack of skill that causes it. Whereas our skill, if it is so gross that it kill the patient or cause severe harm to the patient, from a civil negligence, it can become a criminal negligence. Most quoted criminal negligence is a case called Dato. This is an anesthetist who anesthetized a young child, and there was a disconnection in the ET tube to the tubings of the ventilator, and the child died. And Dato, apart from being reprimanded or sued for civil negligence, was brought to court with a criminal negligence charge, and he was disbarred, or he was deregistered in the UK. In Malaysia, seldom we see criminal negligence among against doctors, unless his action is so bad, causes severe harm, and the patient's death. So far, in the last few years, we've not seen it. The closest we've seen is some doctor who actually killed the patient unknowingly. This has happened, and I was involved in it about 10 years ago. A civil negligence goes to a civil court. In a civil court, the rules, the way you defend yourselves are completely different from a criminal court, which I'll talk about in short. In a civil negligence, the patient has to prove a strong beyond probability that you did not do it correctly. Whereas in a criminal court, the plaintiff has to prove beyond reasonable doubt, 95% proof to convince the judge that you have done wrong. Whereas in civil negligence, the patient just have to prove on the balance of probability, most likely you didn't do it. Okay? So in civil negligence and criminal negligence, there are different ways of doing, of differentiating them. Most medical negligence is a civil court. And in civil negligence, you have to differentiate whether it is a professional negligence, which is what you do, or a professional misconduct, how you behave. Therefore, now you can see the difference between civil and a criminal, and in a civil, whether it is a professional misconduct or a clinical misconduct. A professional misconduct goes to the MMC, which Dato Anit has talked about. A professional misconduct can come to court as a civil suit. So the difference is mainly in the punishment, in the outcome. In the civil negligence, you get punished, pay compensation. Rarely you go in imprisonment unless it's a criminal misconduct. Whereas a professional misconduct, the MMC will warn you, suspend you, deregister you, and things like that. Okay, both in professional misconduct and negligence, you can appeal if you think the decisions are wrong, are against you, and you do not think it's right. In a professional negligence, you can appeal to a higher court. Most medical negligence start off at the court, at the high court, and then you can appeal to the Court of Appeal, and then you have two appeals, one into the Court of Appeal, and then goes to the federal court. Now this is called federal court, previously it's called the Supreme Court. Whereas if it's a professional misconduct, Previously, you only have one appeal. You can appeal only to the High Court if you are not happy with the MMC decision. So you can appeal and say that MMC decision is not right, this is against me, it's penalizing me for no reason. You can appeal to a High Court. With the new regulation, you can appeal to, you can have 2 appeals. So I always look at as an improvement, because in professional misconduct, which is your rice bowl, previously you can only appeal once, whereas in other civil cases you can appeal twice. You have two sources. You have 2 avenues of appeal. So now maybe it is better. You are treated just like anybody else. You can appeal twice. Okay. Now, what is you mean by negligence? The definition of negligence. Like most cases in medical law, they start off with common law cases. And then because medical law is a subspecialty of common law, it derives most of its workings, most of its definitions, and how it goes about doing things in medical law and medical negligence based on common law. And in common law, definition of common law of negligence is as, if you look up the definition in the medical textbook, legal textbook thought, most common one people use is Winfield and Jolowicz. It says, definition of negligence is a breach of a legal duty to take care which results in damage undesired by the defendant to the plaintiff. Therefore, it means that you must have a legal duty which you did not do properly and resulted in a damage to the plaintiff. And this is seen in the very earliest cases. It says that in Blythe and Birmingham Waterworks, where Birmingham Waterworks laid down pipes, and during one very cold winter, one of the pipes broke and flooded the plaintiff's house, which is opposite the piping system. And he sued Birmingham Waterworks. And apparently, the Birmingham Waterworks did their job very, very well with no negligence involved. And in that case, negligence was defined as the omission to do something by a reasonable man. Therefore, your duty is by a reasonable man, guided upon those considerations which ordinarily regulate the conduct of human affairs would do, or something which a prudent and reasonable man would not do. Therefore, you have a duty, and that duty must conform to the duty which a reasonable man would do or not do in your area that you are doing it, not compared to anybody who just anybody. Okay, so it must be a specific group of people that are doing what you're doing. It must be to that standard that people in that group will do, or people in that group normally will not do. Therefore, you can see the definition is slowly coming up. And as the cases come up, the definition of negligence slowly evolves and becomes more concrete. Okay, iron and coal, it says that it properly connotes the complex concept of duty, breach, and damage, therefore are thereby suffered by the person to whom the duty was owing. So now you can see the definition of negligence in general, not medical negligence. Definition of negligence in general is being formalized and being concretized, and you can see what are the components to it. Therefore, is it an error that can be called negligence? Not all errors are negligent. If you look at the definition just now, not all errors. It is the failure to meet the standard of practice in that specific area. Therefore, if you are a doctor, it is the failure to meet the standard of practice in an average qualified doctor practicing in the specialty in question. Therefore, if you are a surgeon, you did not meet the surgical standards, then you are, and the error ensures, then you are negligent. I cannot judge a surgeon using an anesthetist standard, nor can I judge an anesthetist using a surgeon's standard. If it is a GP, I have to judge the GP according to a GP's standard. Did he refer? I do not expect a GP to know everything detailed about some surgical subspecialty. Okay, so here we are beginning to say that these are the standards we have to follow. Okay, it occurs not merely because there's an error, but when the error exceeds the accepted norm. This is what we are most important we have to understand. You can do you understand that in medical science, it is not an exact science. Therefore, you will have errors at any time in your practice. And if you look at negligence in all hospitalizations is a small amount of claims. But if you look at errors are very, very big. If you look at the American way of classifying errors can be about 30 to 40 times of what happens in the hospital. But negligent claims are very small compared to errors. Okay, so now we talk about medical negligence. Now, medical negligence is a subset of common law negligence. Therefore, it has to be very specific for medical negligence. And I have made it very simple to say the anatomy of medical negligence is the 4 Ds, not the 4 digits that you see the magnum. Okay? It's the 4 Ds. Number 1, a duty is owed. Now, this is very, very important because a lot of doctors do not understand what is the duty. Most of us understand duty as a duty. The minute the patient comes to you, you develop that duty. You created that duty already because you decided to see the patient. But a lot of times, duty happens outside where you see the patient. You talk to the patient on the phone, you give an unsolicited advice over the phone. That is a duty itself. Now, that has to come into real issues now. This because we are of our COVID situation now. A lot of our advice and consultation comes internet and things like that. Duty is also owed, not only to the patient, to the patient's immediate people who are involved with the patient, a third party. For example, the patient is pregnant. You do something, you prescribe some medication which is not right for the patient. The baby suffers when she's born. Now your duty to the baby rises the minute the baby is born when something is wrong. Or you did not advise to the patient, I'm giving you this medication. Please do not drive a car. If you do not tell the patient do not drive a car, do not operate heavy equipments and tools because this medication has some sedation, and the patient actually goes out and does it and has an accident or hurt somebody. That third person who you have no contact with, you have no idea with, you owe a duty to that person who is already injured by your patient. Therefore, there's a duty to a third person that a lot of people do not understand will happen. Okay, so you must advise the patient. If you do not advise the patient goes out, have an accident with the third person can sue you for duty not for your breach of duty, not telling the patient not to drive. But in other words, if you had told the patient still drive, then your duty is absorbed. So there's a break in the chain of events. Okay. Number 2, there's a dereliction of duty. Most people will say it's a breach. It is not a breach because it is you do your duty, but you do not do it at the correct standard. Okay, and duty is performed below a standard of care. Right now, this is the most important thing in medical law at the moment because when people sue you, you are judged according to their standard. Previously in medical law, there is no such thing as a standard because any doctor can do anything. In this country, even when I was a specialist already, there is no such thing as a specialist register. Therefore, an ENT can do a general surgical case, a general surgical case can do an ENT case, a general practitioner can do anesthesia, an ONG doctor specialist can give anesthesia because there is no specialist register. Therefore, I cannot say you cannot do this. Now, there is a specialist register. If you are going to do something outside your area of specialty, outside your registration, you will be held accountable as the standard of that specialty that you are practicing. Unless it's an emergency and things like that, then we have to talk about emergency situations, which is completely different. So standard of care is very, very, very important. It is the standard of care in this country. When it comes to clinical standards, we are still following the Bolam standard of clinical care, in contrast to the Rogers, which is how we give advice and take consent. Bolam is very interesting because if you do not know, I can talk to you about later. Number 3 is there is a direct causation to the damage that has resulted from the breach or the dereliction of the duty that you have done. So therefore, you see, in medical negligence, the 4 Ds are very important. They must all be present before a medical negligence suit can be successful. All right? And you must remember, I told you just now, medical negligence is a tort. It is not a crime. Therefore, the proof in medical negligence, in a tort, it is a civil proof. You have to convince the judge that it is more probable than not that this doctor did this or did not do this. Therefore, just pass the 50% mark. Whereas in the criminal case, the criminal proof is beyond reasonable doubt. That means you must be absolutely certain of all the facts and they fit into all the things that you're going to prove to convince the judge that, of course, this plaintiff has, this defendant is wrong. So this is the big difference between civil and criminal cases that come to court. Okay, commission or omission. It is not only what you do, it is what you are supposed to do that you did not do, which a normal doctor should have done. It is not only what you do, it is what you did not do. Which is very, very important because in a lot of times, things that we did not do, that things happen because we did not do things. Delayed diagnosis, we sat on it instead of doing it immediately. So you see, it is not only omission, it is also commission that can create negligence. Okay? Okay. For example, act of commission, what you do, giving an overdose of drugs, for example, propofol. Before this, propofol, even for people who are working not in the anesthesia, were using propofol to give sedation. Hence, propofol, when it first came out, was a very dangerous thing. And people were giving sedation with propofol. Non-anesthetists giving sedation with propofol. Nowadays, most hospitals would have standing instructions that say propofol can only be given in the operating theatre, in the cardiac cath lab, or in the ICU, under supervision or by an anesthetic trained doctor or an anesthetist, not just anybody else. Whereas midazolam and things like that, everybody is using it. So you see, just because you know how to give it, you are not in the same profession, you should not be doing it. Giving the wrong medication, which is ignoring contraindications, which I will talk to you about in one case which I want to exemplify. Giving drug and the route of administration is wrong. Instead of giving IM, you give it IV and things like that. Giving drug at the wrong timing. Giving inappropriate instructions. Giving inappropriate combinations of drugs, for example, anticoagulant and NSAID and things like that. Ignoring serious drug interactions and giving it wrong to the wrong person, for example, giving ACE to pregnant patients or warfarin to pregnant patients in first trimester specifically. So common errors can lead to negligence. There's so many of them. Failure to take an X-ray with the fractures, you operate on the wrong digit or on the wrong leg and things like that. You remove the wrong organ, which we see the news every now and then. We give blood transfusion mistakes of clerical error. Now this blood transfusion is so quite safe that transfusion reactions are quite rare. The most transfusion reactions nowadays happen because of clerical errors. And the most important thing nowadays, people give blood without proper documentation why blood is being given, and risk of getting HIV and things like that in the window period is quite high. I'll show you later in consent if I have managed to do it. Anesthetic mishaps, yes, everything happens in the OT, people blame the anesthetist. Tight plaster, wrong site operation, wrong patient operation, same name, RN nearly the same, but different patients. We have seen this before. Paralysis from things like that, splints and things like that. Even under anesthesia, when the patient is paralyzed, you have to put the arms or the legs in under pressure and compress the nerves and things like that. Retain objects, we still see some of that happens So our swab counts, sometimes in OT, I know swab counts not correct, we have to reopen the chest and recheck again, take an X-ray, is the swab count correct, the swab count not correct, is the chest the swab still there, and things like that. So all the common errors that can lead to negligence are there. And for our purposes, we have strict SOPs. 30 years ago, 40 years ago, there are no strict guidelines, strict SOPs. So people depend on doctors to say, yes, this is okay, this is not. Now, doctors, every college has come up with such guidelines that the guidelines become so like a straight jacket sometimes. People are scared to have individuality in their management. Okay. 6 common causes of medical negligence that we've seen most common. Number 1, misdiagnosis. Number 2, delay in diagnosis. The condition becomes worse. Last week I gave a talk at the Intensive Care Society. The 2 most common, the most common cause of negligence in intensive care is delay in diagnosis. Basically, because in intensive care, we deal with patients who cannot communicate, who cannot articulate with us and tell us exactly what is their problem. We depend on our results from blood investigations, from CT scan, MRI, and things like that before we actually come to a diagnosis. You must be very, very skillful, and in that intensive care, things change very fast. Therefore, the delay is always there in intensive care. So one of the biggest issues in intensive care, I talked about last week in the intensive care meeting, is a delay in diagnosis. Fail to maintain update standards and skill and care. Because number 1, you have too many patients, you don't have time to come for CNEs. You will find that you will fall as you grow older. You will fall into this pitfall. When you're young, you do not update because probably economic reasons, profits over safety. But as you grow older, you see too many patients, you fail to maintain and update standards, and you find that as you grow older, you have become so ingrained in what you do. New things coming up, you don't catch up, and you don't see the things coming up. And I can tell you this from experience, you tend to lag behind in terms of development. Therefore, your standard is still standard of the new college in a standard, which you are using the old college in a standard. So you have to be very careful. When you are young, you fall into different pitfall. When you grow older, you fall into different pitfall. It's a lecture by itself, I can give. Okay, birth injuries, yes, I've talked to the medical legal department in Ministry of Health. The biggest amount of payout goes out to obstetrics and pediatrics, specifically in birth injuries. Okay, medical product liability, this is going to become a big issue nowadays because there's so many companies trying to promote their drugs and their new equipment that health industry or allied health industry has become a big business by itself, and doctors have to be very, very careful how we deal with them, not to be economically involved with them. Some doctors even set up companies to be involved with them. So you have to be very careful from an ethical business point of view, not creep into professional clinical judgments. And of course, surgical errors, these are all the surgical errors that we talk about in unnecessary surgery and things like that, which I talked about. This is becoming very common, unnecessary surgery, because it is regulated by the health insurance companies, whether to pay or not. Okay, misadventure, sometimes things happen. You can classify as misadventure because there's hypersensitivity, idiosyncratic drug reaction, and things like that. If you remember, somebody mentioned about hypersensitivity to the drugs they gave to a person who came for dental extraction and died in the dental chair, which is very rare. And the sedation was given by a person who is so-called did anesthesia posting, but it's not an anesthesia. So that case came out as a misadventure. But it could have gone the other way around, it came out as a criminal proceeding. But it didn't, thank God for him. So medical negligence, you can see that the most common thing we see is failure to diagnose, failure to treat, inadequate treatment, and things like that, complications, side effects. The last one I want to mention specifically is emotional distress. This is slowly, it has a few cases that come out overseas, but in Malaysia, I've not seen this advertised as much as overseas. Emotional distress. How you treat the patient, it can become a professional misconduct. But if the professional misconduct has caused has caused emotional distress in the patient or his relatives, they can bring up a civil suit in the civil court apart from the professional misconduct. This is seen in Farrell and Merton, Sutton and Wandsworth Health Authority, where a patient delivers twins, and the first twin came out, the second okay, the second twin came out bad, was stuck, and there was a lot of issues with it. The second twin died. But the way in which the news was conveyed to the mother while she was still in shock in the hospital causes so much distress. There was no empathy from the doctor that gave the information, and information was just given in a very blank, sudden information. And the mother got a nervous shock from there. And that can be a cause of civil suit. And this we see in the recent case in Singapore, Pang Hassan versus against the Singapore Medical Council, how doctors are so unempathic about a child who's got a tumor in the brain, and how the parents were treated, that they were not talking to the parents properly and hiding facts from the parents. That has caused a lot of emotional distress. Therefore, your empathy, the way you convey messages, the way you communicate with your patients and their relatives are very important, especially in an Asian sense of society. So what I find out is that we are trained very well on our clinical judgment. Doctors in medical school nowadays are being trained how to communicate. Communication is the big issue. A lot of medical negligence is based on communication, miscommunication, communication errors. That is a big issue that we should address quite acutely nowadays. Some defenses you can say against medical negligence: no duty. For example, I have no duty against the person that my patient had an accident with, because I have told my patient, do not drive the car if you're taking this medication, or do not drive after this day case anesthesia. You must bring somebody to take you home. And I can tell you very well, because I have advised one patient, do not drive this day case. I anesthetized her in the morning for a small abscess removal. And then I was going home at 12 o'clock. I said, you must have, at the pre-op, I told her, you must have somebody bringing you to the hospital or somebody taking you home. Otherwise, you have to take a taxi, whatever it is. And at 12 o'clock after lunchtime, it was a half day in those days, I was driving home, and I saw this patient driving home, overtaking me. It was difficult to reconcile with that, because this patient happens to be a senior consultant in the hospital. The doctors are the worst patients. So no carelessness, there was no carelessness, and I had my defense is that I have followed the standard guidelines, I followed the guidelines given by my colleges, and my records are good and things like that. There's no carelessness. Therefore, something went wrong, and medical science is not an exact science. Something can go wrong, and it did went wrong, and I've already informed you. So there's no carelessness, there's no damage. And no damage. In the old days, we talk about no damage because no damage of physical damage. But nowadays, remember I told you about mental damage? That can become a sole source of civil suit. No direct causation because somebody else intervened in it. Therefore, when they sue the hospital, you can see she's not only suing the person who takes care of the patient, everybody down the line, so that they can find out who intervenes in between. Okay, out of time, which is the period of limitation, which the lawyers will try and fight in medical. I will talk about it in one of the statutes I'll give at the end. No evidence of negligence, no breach of duty. These are your defenses. And lastly, consent. Consent is very important. Sometimes, even with consent, if you're doing the wrong thing, it is still in medical negligence. Okay, I will talk into that detail because that's a separate by itself. Okay, so how do we reduce exposure to medical negligence? This is more important to doctors. Number one, knowledge. You must know something about medical negligence before you actually come out to practice. Number two, we must teach you how to communicate properly with our patients. There's defensive medicine and there's defensive talking You need to learn how to talk with patients. That's why mediation is very, very important. I think most doctors, all doctors should undergo some form of mediation training, how to talk properly to the patient. Keep an open mind. Do not say I'm doing the right thing and not listening to the patient. Okay. Good record keeping. Good record keeping is your second line of defense. Good record keeping, not only writing everything down legibly. Last week when I talked about intensive care is the worst place to have record keeping because there were 5-6 consultants coming in, writing different parts of the ticket, and different consultants have different handwritings. And for me to decipher when I look at cases, it's terrible. In contrast, if you have only one consultant looking at patient, it is easier to follow. It's intensive care, there'll be multiple specialists writing in interspersed between the intensivists in your notes. Terrible. Skill development, yes, you must update skill. Equipments, new equipments, old equipments must be maintained. New equipments, you must be trained before you use it. You must have a proof that you have been trained in it and things like that. Updated techniques, attention to what's wrong. This is my lecture on reducing exposure to litigation. I made it very simple, A, B, C, D, E. This is what I give to my students lectures. Each is a talk by itself, therefore there are 5 topics there. There's 5 lectures there. Number 1, to be aware. How do you become aware? You subspecialty, what subspecialty you have to be aware with, what issues. You must be aware, who you must be aware. For example, if I'm an anesthetist, I have to be aware who the performer is, who's the surgeon, who's the orthopedic surgeon, who's the general surgeon. Has he been sued before? Is he a repeated issue coming up with MMC or medical litigation? You'll be surprised that in any hospital, 10% of the people are responsible, 10% of doctors are responsible for more than 50% of the problems caused in the hospital. Therefore, you have to be beware of the performer, beware of the procedure. It's a simple procedure, it's a complicated procedure. Will this procedure produce this kind of complications? And also you have to beware of the patients. For example, Rogers and Whittaker, the patient is very, very particular about what's going to happen to the other eye. And in Malaysia and in context, not only you have to beware of the patients, you have to beware the patients and his or her relatives. See communication, confidentiality, capacity, and capacity of the patient, and comments specifically by your colleagues. Usually when something goes wrong, a colleague in another specialty will make comment about the procedures of a specialty. And this is very bad because patients picked it up and used that as the basis of starting the legal suit. So that's a talk by itself. D, defensive medicine, how to practice defensive medicine, how to write properly, documentation, and delays, especially in patient grievance mechanisms. E, education, which we must introduce into medical school and explore ADR, alternative dispute resolution, specifically on mediation, which I think Shanti will talk about. So my ABCDE is a topic, each subspecialty, each alphabet is a topic by itself. There's about 6 lectures I can give to you if you're. So case example is Dr. Murray, a very famous doctor there, Conrad Murray. He owed a duty to Mr. Jackson, I'm sure you know the late Mr. Jackson, to act in a manner befitting his profession. Now, what is his profession? Dr. Conrad Murray is a cardiologist. He is not an anesthesiologist or trained in anesthesiology. But what did he do? He prescribed and administered propofol in Mr. Jackson's house, in his home, which is a very unorthodox practice, because when you give such powerful drugs like propofol, you need to have proper monitoring systems and proper resuscitation systems. Okay, so this by itself is a major breach of standard of care. And propofol should be given in a hospital setup, monitored, skilled people around there, and thus, there you see, that is the first thing that Dr. Conrad Murray did, is to breach his professional standards. Clinical standards are breached because he is not doing what an anesthetist is doing. Therefore, guided by what you're, so if you are a general surgeon, you try and do a ENT procedure, for example, tracheostomy, when there is an ENT surgeon around, then when things go wrong, I will judge you according to the ENT standard. not to a general surgeon's standard. And they are completely different, I can tell you that. Okay? So combined with other drugs, apart from the propofol, he gave him some other narcotics as well. The singer went into, Mr. Jackson went into cardiac arrest. And Dr. Murray failed to perform CPR as a person who is qualified as a cardiologist. You do CPR on a bed which has no flat hard surface instead of doing it on the floor or on a bed with a hard surface. How can you do CPR on a normal bed? Okay, all these things prove that the breach of duty is done there by Dr. Murray. So you see, this famous case proves to you that all the ingredients are required. One, he has a duty. Number two, he did not do his duty properly. And it is a direct causation of Mr. Jackson's damage, which is death. Okay, I just want to bring up one case example in Malaysia, Chin Kiao, which is a very important case to me and the government of Malaysia, and I put some of this picture there. Chin Kiao is an ama working, and he has a sore on her foot. She went to one government hospital and they gave her cocaine penicillin, and she developed a rash after the first injection. So she was told that she has an allergy to penicillin. Now, a few months later down the line, she had a similar infection. So she went to see another doctor. And this doctor, she saw the nurse outside, and she told the nurse she had an allergic reaction to the penicillin given to her a few months ago. And the nurse took her notes and gave it to the doctor. The nurse did not tell the doctor. And she comes into the clinic, and the doctor looks at her, examines her, looks at her notes, and then gives her another similar drug injection. And she developed a severe allergic reaction, second time exposure, and she died. So the doctor did not inquire from her whether she has any allergic reaction. The nurse did not tell the doctor, and the doctor did not specifically ask. So this is the doctor's duty. He went to court at the first instance. At High Court, the doctor lost. So Chin Kiao's relatives or sons managed to get compensation. The government appealed. It went to Supreme Court. Now this is where you understand in the old days, judges may not be as knowledgeable or informed about medical things. So at Supreme Court, it was overturned. That means the doctor prevailed. Now, this lady, Tan Sri PG Lee, she was in private practice. She took this case to the Privy Council. In those days, we can go from Supreme Court appeal again and go to Privy Council. Now we cannot after 1994, I think they abolished that. So we cannot go to England and ask for direction. So PG Lee took this case on her own under the Poor Persons Act or Poor Persons Location, go to Privy Council. And the Privy Council said, yes, there is a breach of the doctor. So in the old days, the doctors are sort of protected a lot by law because most doctors are in government service and most judges tend to be pro-doctors. Nowadays, the lawyers and the judges are more knowledgeable, cleverer, they have seen more things, they do not need that kind of judgments anymore. So you guys, be careful. Okay, now let's have a look at some litigation related to not anesthesia, but this is a things relation to anesthesia. But in this paper, they classified all the subspecialties that have litigation. And of course, ONG surgery is the highest. Anesthesia will come down to this. And I'm very cautious about this because when things happen in anesthesia and in the operating theater, everybody is calm because always the anesthetist is at fault. And in Malaysia, we also have somebody who has published, my late boss, mentor, Dr. Krishna. He did a survey of all medical litigation aspects of anesthesia in Malaysia. And also, by specialty usage, you can see that ONG about 28%, general surgery 21%. So you can see ONG high on the list. You're living probably with 2 patients, probably 2 normal patients, 2 lives and things like that. So your incidence is quite high. And if you look at the data from Ministry of Health, this is the only data I can get until 2019, the medical legal complaints in the medical MOH, newly filed medical legal cases, slowly goes up, which is about 200 plus per year, which is 4 cases per week, which is a lot. This is only the Ministry of Health. And if you look at it, the Ministry of Health tries as far as possible to pay the patients rather than bring it to court. Remember, if you bring it to court, number one, it takes much, much longer time compared to just pay ex gratia. Number two, it costs a lot. Number three, it costs a lot of distress to the doctors and people working on the case. And you look at it properly, the amount of money the ministry has spent is about 20 million per year on litigation, or on covering medical litigation alone. And if you look at the number of ex gratia and the cases actually go to court litigation, for every case that goes to court, it costs nearly 4 times more for the government just to pay ex gratia only. So going to court is very expensive. Therefore, try not to go to court. And one of the alternatives is mediation, which our ministry have to look into it. Government has to look into it very, very seriously. Okay. Lastly, one of you acts, you must know that if you are a tort, takes 6 years of limitation. So if you do something wrong today, the patient has 6 years to sue you. Do not think that by the first year, second year, nothing happens, nothing will ever happen. They have 6 years. But if you work in the government hospital, you are protected by the Public Authority Protection Act, which limits the duration to 3 years only. And if there is a death, they must bring the suit within 3 years. But if you are a child, the child grows. The child has until the age of maturity and 6 years or the 3 years, whichever position the doctor is in, to bring the suit. So if you're a pediatrician or somebody working with pediatrics or you're a pediatric surgeon, you have at least 21 years the case can come up against you. For example, in Van Smith, it took nearly 8 years or 9 years before the case comes to court. It takes about nearly 20 years for the case to finish to court. So you remember, even if you have done everything right, coming to court is a great stress. And remember, not only 1 year, 2 years, 3 years. Nowadays, you're lucky because the cases take only about 2 or 3 years to come to court and finish to settle, unless it is appealed to Court of Appeal or federal court. So every time a lawyer's letter comes to you, the stress you can see is unbearable. Okay, so my last 2 slides is to say that, is it the act of being negligent? Do you intend to do it? Therefore, that is why in medical law, it's very difficult to come to criminal conviction, criminal charges, because the act is important in a crime. Actus reus. You must do it right, and you must do wrong, and you must intend to do wrong. And it is very difficult to prove that the doctor intends to do wrong things. So is it the act of being or the knowledge? Most likely it's the knowledge of medical negligence, and number 2, how to avoid it. So a lot of medical negligence happens in medical school, not because you act in medical practice, not because you want to do it, but because you don't know about it and you do not know how to avoid it. So my question always when I do this talk is to ask teachers, universities, not ask the doctors. Are we negligent if we do not teach medical negligence to those who will be exposed to medical negligence? So who is negligent now? You see, in law school, I go to law school. In law school, they teach lawyers medical negligence as a separate topic, as a separate subject by itself. But in medical school, we are never taught medical negligence. Now, so look, who will be advantageous in this respect? So thank you very much for listening to my lot of overdoing it. Thank you very much.
Thank you very much, Dato Hassan. I always enjoy listening to your lectures since my student days. It's very, very interesting and a lot of information that we can gain.